Hello, my name is Dr. Krishna Sheshatri. I'm an endocrinologist from Chennai. I have with me Dr. A.Ramachandran, one of the outstanding diabetologists of the country, and we're going to have a little chat about insulin therapy in view of the new guidelines that are emerging. We have with the new risk stratification approach that has crept into the guidelines, looking at ASCVD first, and then look and A1C actually taking the next step to ASCVD. Where would you place the position of insulin? I'm sure you remember a time when the ADA algorithm started with metformin and then went to insulin, but it's way further down now, isn't it?
Yeah, I think the new ADA and the ASD guidelines, for many reasons, have been much more pragmatic, and also depends upon the clinical profile of the patient rather than blindly following a guideline. And I think that what I like about it is that it has stratified patients according to the comorbid conditions as well as even the cost. So that is very important. Now, after many years, we are now in an era where we have newer molecules or newer agents which have shown promising results as far as cardiovascular risk is concerned. We all know that in type 2 diabetes, the most important cause for mortality and morbidity is actually cardiovascular disease. So therefore, the ADA has stratified the patients to those with risk of atherosclerotic heart disease, or those people who already have existing atherosclerotic vascular disease, those who have renal disease, and then compelling need for patients who have obesity, and those patients who have an increased risk of hypoglycemia. And the last thing is much more important, especially as India is concerned, and that is about if cost is a concern, they have said that is a different type of approach. As you rightly said, as well as now with the specific questions about insulin, till last guideline was published, insulin has been one of the mainstay for treatment of any type of diabetes, especially type 2 diabetes. And after metformin, one of the agents which could be used is basal insulin. But today, insulin has taken, in the hierarchy, it has gone down for a simple reason. We have other agents which are shown better results, other agents which are not even injectables, and even in the injectables, we have things which are more acceptable than insulin for many reasons. Therefore, insulin has gone down in the hierarchy of the guidelines for type 2 diabetes.
So, but are there still patients in whom you would say, and I'm talking about type 2 in this, that you would say, you know what, let me start with insulin?
Well, if you have symptomatic patients with pretty high levels of hyperglycemia, and let's say the HbA1c is 10% and blood glucose is 300, and the patient is symptomatic, patient is in a state of what is called glucose toxicity. That is a time you may start to initiate insulin for definitely to reduce the glucose toxicity. I do not think that we should depend only on oral hypoglycemic agents or any other type of insulin secretagogues in that scenario.
And the new guidelines do actually talk about a resource limited setting, and insulin does actually happen to be one of the cheaper alternatives to some of the newer products.
I think you're right. I think one of the most important things we like about this new guideline is that they talked about people who are economically backward or resource limited settings, where you can think of using drugs like metformin and then go for sulfonylurea and also use insulin, because considering some of the new agents which are available, insulin is still economical to use and has got definitely robust results as far as glycemic response is concerned.
Thank you, Dr. Ramachandran. Before the advent of basal insulin, and for many years after the advent of basal insulin, India along with probably China has always been a premix market. While there are some changes to it, India still remains a premix country. Yeah. For the first time, however, we are also seeing the word premix creeping into the guideline. The IDF and the WHO already have it. There are some Asian guidelines, but you're seeing the words used in Western guidelines increasingly. Are they too late to realize to it? Are we looking at mostly a population-based preference that is seen? What should be our approach?
I think there are a number of reasons why we in India prefer premixed as the first line of insulin therapy. One of the reasons is because we find from the public health point of view, from an epidemiological point of view, insulin started a little late in India. So the average HbA1c is almost about 9 in the population of type 2 diabetes when physicians initiate insulin for different reasons, from the point of view of patients' barriers, patient-related barriers to accept the daily injections of insulin, and also from the unwillingness for physicians to start somebody on injectables like insulin. So therefore, when you start patients on insulin with a higher HbA1c, usually they not only have higher fasting, but they also have a higher postprandial plasma glucose. Now, more than that, for a given HbA1c, when you compare the fasting and postprandial plasma glucose levels in the Caucasians compared to the Indian population, we always find that for any HbA1c level, postprandial plasma glucose levels are much higher. It may be related probably to the type of diet that we take, because as you know that the typical Asian or the Indian diet contains almost 60 to 70% of carbohydrate. Therefore, even if your fasting is not high, your postprandial tend to be much higher. Therefore, I think there is good reason for physicians to believe and to accept and start premixed insulin as the first type of insulin to start with, so that you not only target the slightly elevated fasting, but also at the same time target the postprandial hyperglycemia.
And truly, contrary to the Monnier study, which looked at Caucasians and showed that there's a higher contribution of fasting to A1C at the highest A1Cs. The Weng study, which actually looked at an East Asian population, showed that at the highest A1C, there is still a significant prandial contribution. Also, the longer the duration of diabetes, the greater is the prandial contribution to the A1C. And I think that brings to your point that insulin is actually not an early starter, but a late starter in the Indian population. So premixes continue, and I think the Western guidelines have slowly started to recognize the value of having a single pen, the ease of using one insulin versus many insulins.
Oh yeah, sure. But if you are starting insulin but a little late stages like HbA1c 10, and there's no doubt that you had to think of both long-acting and short-acting insulin. There's no doubt about it. But why the basal insulin is the first choice in the Western countries is because most of them start insulin pretty early and the difference between the fasting and the postprandial is not very high. So they target the fasting. The usual slogan is fix the fasting first, and therefore they always start basal insulin first. So majority of the patients are to start with our own basal analogs in the West, but that is different in our country because we start insulin late, and secondly there is always a big difference between the fasting and the postprandial, and targeting postprandial is crucial in getting a better guidance.
And even if the basal is a starting insulin, in many instances in our patient it happens to be just a bridge insulin, because you will quickly have to move on to a second dose. So starting with a premix actually makes sense in many of our patients.
Absolutely.
Now I'm sort of going to take you on this. For many years, the holy grail has been, basal and then basal bolus or others, and given our patients, many of the times the good is sacrificed on the altar of the ideal. And one of the reasons that we have never been able to show in the past about premixes being comparable to basal boluses has just been the design of the study. Some of them have looked at different non-inferiority clauses, absence of forced titration, absence of patient-driven titration. But I think we're now seeing evidence to show that we may not be titrating as well as our patients, isn't it?
I think the reason why the basal bolus or the basal plus, what it became a popular regimen, was because of the reason that when you start basal, one of the adverse effects of starting insulin is one of the one of the side effects or one of the fears that patients as well as physicians have is hypoglycemia. So the reason basal analogs became popular is because you can start insulin and fix the fasting without the risk of much of hypoglycemia. That is the reason why in the Western countries you have the basal bolus becoming much more. So, and once the basal is started, and then you find the fasting is under control, and then you find after some time the postprandial blood glucose are not under control, then you start a bolus insulin. You may start with 1 bolus, or they go for 2 bolus, or 3. So the basal bolus became popular that way. On the other hand, in India, from the beginning, we have been always using premixed insulin, and I think we have been wiser, probably,
True.
for many reasons. And now we have consensus coming up that actually premixed insulin are pretty good, and in fact we have now randomized control trials comparing basal bolus, basal plus with premixed insulins, showing that perhaps there are conflicting results. Some of them show that in some studies they have found that basal bolus reduces the risk of hypoglycemia, but in other studies shows premixed insulin given a couple of times a day actually have better glycemic control, and the total dose of insulin is much better. So therefore, I think starting premixed insulin as a first line of therapy is still, we are not wrong. I think it is still probably one of the best. And I think, as you rightly said, there is now the new guidelines coming where you can use premixed insulin a couple of times in the beginning, and even it is also in the guidelines say that 50-50 insulin can be used even up to 3 times a day.
Right. In fact, there is even older data showing that, at least with the mid-mix insulins, that using it 3 times a day had greater A1C reductions. And it's very interesting that you see the evolution from this is the only way to do it, to there are many ways to get there, and the beauty of this whole thing is that patients as well as physicians have a greater choice in choosing what works for them, and it's really an application of individualized care.
I think absolutely right. I think finally it boils down to what is the most acceptable regimen for the patient, and what the physician decides depending upon his clinical profile, his glycemic profile, and his acceptability of the number of injections, and his risk of hypoglycemia. So I think it has to be highly individualized. The guidelines will definitely tell you what you can do, but what is finally acceptable, finally fits into the patient's is depending upon his individual response to therapy that you give.
So with the comment that that sometimes the ideal has to be sacrificed for the greater good. I will thank Dr. Ramachandran for this amazing wisdom that he has provided in the past few minutes, and grateful to all of you for having listened to us. Thank you so much.
Thank you.